Welcome to the deep dive. Today we're really getting into the core of surgical practice. We're talking about the moral architecture, the ethical, legal, practical frameworks that surgeons use when they're facing these incredibly tough, life-altering decisions.
That's right. Our mission here is to go beyond just, the basic principles. We want real mastery. We're digging into the foundational texts that really define professional conduct, especially in critical care and when dealing with end-of-life situations.
It's about understanding that blueprint for elite professional conduct, as you said. And it's complex, isn't it? Because it's not just about the patient and the surgeon.
No, not at all. The ripples go outwards. The surgeon has obligations to society, to their own integrity, and often they're making calls under immense pressure with information that's, well, incomplete. Every choice has risks.
That really sets the scene. How do professionals navigate when there isn't one single, clear, right answer? Let's start, I think, at the philosophical roots. Where does ethical decision-making in surgery begin?
Well, we have to start with Aristotle. With the Greek concept of phronesis, this is really where the rubber meets the road in surgical practice.
Okay, phronesis. We hear that term, but unpack it for us in this context. Why is it so central?
So phronesis basically means practical wisdom. It's that ability, that capacity to figure out the best path forward when all your options are. Well, imperfect. It's not like technical skill, which you can teach and execute perfectly.
Okay.
Phronesis comes in when the data is messy, outcomes are uncertain, maybe values are clashing.
So, like repairing a straightforward hernia that's mostly techne, applying a known skill,
Right.
but a massive trauma case, rolling into the ER, bleeding heavily, unknown injuries, clock ticking, that demands phronesis. You need the skill, sure, but also the judgment about prognosis, family wishes, maybe resource limits, all at once.
Exactly. That's a perfect example. It's integrating the technical courage, facing the bleeding with the wisdom to know when maybe stopping is the right call, or changing the plan, or how to bring the family into an impossible decision. It's core to virtue ethics, right alongside courage, justice, temperance.
And the crucial point from the sources is that you can't just learn this from a book.
No, absolutely not. It's developed through experience, which brings us to Charles Bosc, the sociologist.
Right, his argument about residency.
Yes. Bosc basically argued that surgical residency, which we think of as technical training, is fundamentally moral training. The insane hours, the hierarchy, seeing mistakes, confronting uncertainty. That whole system, intentionally or not, is designed to forge the judgment, the phronesis, needed for these critical decisions.
Okay, so you develop this practical wisdom, but you still need a structure, a systematic way to apply it, which leads us to modern biomedical ethics.
Correct. Biomedical ethics is the system of analysis we use to try and guide surgeons towards the good action, the ethically sound path.
And the dominant framework here is the principalist approach.
Yes, Beauchamp and Childress's work. It's hugely influential. It gives us 4 key guiding principles, non-negotiable considerations for every single case. Think of them as the pillars for deliberation.
Let's define them carefully, starting with the one that gets a lot of legal focus. Autonomy.
Autonomy. It's the requirement to respect a person's capacity to choose their own path, their own destiny. It's foundational to patient rights today. It means 2 things, really. The patient has the right to decide about their own body, and the physician has an obligation to allow those choices, assuming the patient has decision-making capacity.
Okay. Second principle, beneficence, often just thought of as doing good.
It's a bit stronger than that. Beneficence means the actions you propose have to actually aim at achieving something good and have a reasonable chance of achieving it. It's an active duty to seek positive benefit for the patient.
Got it. Third, nonmaleficence. The famous maxim comes in here.
Primum non nocere. First, do no harm. Non-maleficence is the principle of actively aiming to avoid causing concrete harm. This is what forces that constant weighing of risks versus benefits for any intervention. Surgery always carries risk.
And the fourth pillar, justice.
Justice demands fairness, especially in how we distribute the benefits and also the burdens of medical actions or resources. Think about who gets an organ transplant or access to expensive new surgical tech. Justice says that distribution needs to be equitable.
So inevitably, these principles clash. Beneficence might say operate now, but autonomy says the patient refuses. What happens then? How do you resolve that?
And that's where the case-based paradigm comes in. The principles don't give you an automatic answer. What they do is force the clinical team to identify what's truly at stake. You have to clarify the competing principles. The values involve self-determination, quality of life, maybe sanctity of life for some. You weigh them, balance them, all in the specific context of this patient, this situation.
So the framework doesn't eliminate the difficult choice, but it clarifies why it's difficult and what needs to be considered.
Precisely. It structures the ethical deliberation.
All right, let's move from those foundational pillars to something very practical, informed consent. It feels so fundamental now, but it's actually a huge shift from how things used to be done.
Oh, absolutely. It completely overturned the era of, well, benign paternalism. That was the norm in the 19th, early 20th centuries. The doctor, acting out of what they saw as beneficence, just decided. Patient input was minimal. Disclosure was thought to just cause anxiety or lead patients to make bad choices.
The legal challenge to that didn't start with needing information, did it? It started with just needing permission to touch. That gave us simple consent.
That's right. The landmark case was back in 1914, Schlöendorff versus the Society of New York Hospital. Mary Schlöendorff consented only to an exam under anesthesia. She woke up to find they'd done a hysterectomy.
And Justice Benjamin Cardozo's ruling in that case was incredibly direct.
It really set the standard for bodily integrity. His words are quoted everywhere. Every human being of adult years and sound mind has a right to determine what shall be done with his body. And a surgeon who performs an operation without his patient's consent commits an assault. Simple as that. Operate without permission. It's battery. The only out was a true emergency where waiting would be fatal.
So simple consent means you need my permission to touch me. But informed consent is a much bigger leap. How did we get from basic permission to requiring detailed disclosure?
Well, initially, medicine tried to handle it internally with the professional practice standard. Basically, a doctor only had to disclose what other reasonable doctors in their field typically disclose.
Which could mean very little if the profession generally kept quiet.
Exactly. It was a standard set by doctors for doctors. That whole approach was finally struck down in a really critical case in 1972, Canterbury versus Spence.
Ah, yes, this is where the power shifts towards the patient, establishing the reasonable person standard. That's the law now.
That's the current legal benchmark, yes. Canterbury said physicians must disclose all the information, the diagnosis, the options, the risks, the alternatives that a hypothetical, reasonable patient would want to know to make a decision in that situation. Adequacy isn't judged by what doctors think, but by what a typical patient needs. It fundamentally shifted power.
Okay, so given that reasonable person standard, what are the core elements a surgeon absolutely must document to show they've obtained adequate informed consent? There are 4 basics, right?
Yes, 4 essential components. First, document that the patient or their surrogate, if they lack capacity, has capacity, meaning they can understand, appreciate consequences, reason with the information.
Okay.
Second, the surgeon must disclose enough detailed diagnosis, prognosis, the nature of the proposed treatment, risks, benefits, alternatives, including doing nothing. Third, the patient needs to demonstrate understanding. It's not enough to just say the words. You need some confirmation they've grasped it. Maybe ask them to explain it back in their own words.
Right, teach back.
Exactly. And fourth, the patient must authorize freely, voluntarily agree to a specific plan without coercion or undue influence. Get those 4 things documented, and you've met the standard for informed consent.
Now let's talk about situations where autonomy bumps up against reality. Emergency surgery is the classic example where full informed consent often isn't possible.
Right. In a true emergency, the limits on autonomy are accepted legally and ethically. The surgeon is justified in acting quickly to save life or limb. The justification rests on the reasonable assumption that most people would want life-saving care in an emergency. Plus, frankly, in the chaos of initial resuscitation, you often don't have the full picture to disclose anyway. Prognosis is unclear. The duty to act outweighs the duty to fully disclose beforehand.
Another tricky area is the pediatric population. Children can't legally consent, and they might lack the maturity.
Correct. Legally, parents or guardians provide informed consent, or more accurately, informed permission. But ethically, the surgeon still has a duty to involve the child to the extent possible based on their age maturity. We call this seeking assent.
Assent, not consent.
Right. You explain things in age-appropriate terms. Even a young child can often participate in some way. It respects their developing autonomy and can really help reduce fear and anxiety.
What about the really difficult situation where parents refuse life-saving treatment for a child based on religious beliefs, like refusing a blood transfusion?
This is legally quite clear, though obviously ethically and emotionally fraught. The courts have consistently ruled that parents cannot place their minor children at mortal risk due to religious beliefs. The state's interest in protecting the child's life overrides parental autonomy in these specific life-threatening situations.
So the hospital needs to act.
Absolutely. The moment this conflict arises, the physician must immediately involve the hospital's ethics committee and legal counsel. They will typically seek a court order to provide the necessary treatment.
Now, here's a real tension point the sources highlight. The doctrine of informed consent puts maximum emphasis on autonomy, precisely when serious illness might be threatening that very autonomy. And yet, the evidence suggests disclosure isn't always that effective.
It's a paradox, isn't it? Study after study shows that patients, especially when severely ill, anxious, or overwhelmed, retain very little of the information disclosed during the consent process. The sheer volume, the medical jargon, the emotional weight, it often just doesn't sink in.
So legally, you've checked the box. But ethically, have you truly achieved informed understanding?
That's the difficult question. It highlights the gap between the legal requirement and the ethical ideal of genuine shared decision-making. We have to keep trying, using clear language, teach back, involving family, but we need to be humble about how much truly gets across sometimes.
One last point on consent.
Yeah.
The process for organ donation has evolved to avoid conflicts of interest.
Yes, it used to be that transplant surgeons or maybe the ICU doctors handling the patient's care would approach the family about donation.
Which could feel coercive.
Exactly. It could erode trust. If the doctor fighting to save the patient is also asking for their organs, the family might feel immense pressure or question the motives. So best practice now, and often legally mandated, is that the request comes from specially trained designated requesters or organ procurement coordinators. These are people separate from the direct care team. Or sometimes an independent intensivist handles it.
Maintaining moral neutrality.
Precisely. It separates the decision to donate from the decisions about ongoing care, protecting the family's autonomy and the integrity of the therapeutic relationship.
Okay, so what happens when illness progresses and the patient loses the capacity to make decisions themselves? We look to advanced directives to try and carry their autonomy forward. Let's start with the most common type, the living will.
Right. A living will is a document where a person outlines their preferences for specific life-sustaining treatments, things like mechanical ventilation, CPR, feeding tubes, dialysis.
Yeah.
But critically, it typically only applies if they become incompetent due to a specifically defined terminal illness.
But the sources point out some real weaknesses with living wills in practice.
They do. Often the language used is just too vague. What exactly constitutes a terminal illness or no hope of recovery? These terms are open to interpretation, and they're often too narrow. They might say nothing about situations like advanced dementia or a persistent vegetative state, where someone isn't terminal in the immediate sense but has lost capacity and may live for years.
And then there's this psychological issue, the effective forecasting problem.
Yeah, this is fascinating. Psychology research shows that healthy people are actually pretty bad at predicting how they'll feel or what they'll want if they become seriously ill or disabled. We tend to imagine it would be much worse than people living with those conditions actually report.
Like the dialysis example.
Exactly. The general public estimates the quality of life for dialysis patients as quite low, around 0.39 on a scale. But patients themselves rate it significantly higher, maybe 0.56. It means our healthy guesses about what makes life worth living can be way off, which really challenges the whole idea of making binding decisions in a living will years before you're actually sick.
So this suggests that maybe the durable power of attorney for healthcare, DPOAHC, is often a more practical tool.
Generally, yes. It's often preferred because instead of trying to predict specific future scenarios, the patient identifies a person, a surrogate decision maker, whom they trust to make decisions for them in real time if they become incapacitated. The focus is on choosing the agent, the person, rather than pre-choosing the action.
But even then, the assumption that this trusted surrogate will perfectly know and reflect the patient's wishes? That's not always accurate either, is it? The data on surrogate accuracy is a bit sobering.
It really is. A major meta-analysis found that surrogates, even close family members, only predict the patient's actual treatment preferences correctly about 68% of the time. That's barely better than chance on some decisions.
Wow, only 68%.
Yeah. It's a crucial finding. It shows that even the person closest to the patient doesn't have perfect insight. But we still rely heavily on the DPOHC because even if the surrogate isn't perfectly accurate, the document does respect the patient's prior autonomous choice of who should make the decision. That act of choosing the decision maker is itself an expression of autonomy.
Legislation tried to boost the use of these documents. The Patient Self-Determination Act, PSDA, from 1991.
Right, the PSDA required hospitals, nursing homes, etc. to inform patients about their right to create advance directives upon admission. It was a big push.
Did it work?
Well, it raised awareness, but uptake is still relatively low. And even when directives exist, they don't always solve the problems.
Yeah.
The famous support trial tried intensively, using specialized nurses, to improve end-of-life communication and decision-making based on patient preferences.
And the result?
Disappointingly, it didn't significantly change key outcomes, like the timing of do not resuscitate, DNR orders, or how often doctors and patients agreed on care goals. It showed just how hard it is to translate these documents into consistently preference-concordant care at the bedside.
It's really important, isn't it, for surgeons especially, to make sure patients and families understand that a DNR or DNI, do not intubate order, doesn't mean do not treat.
Oh, absolutely critical. That needs to be crystal clear. A DNR-DNI order is specifically about not attempting cardiopulmonary resuscitation or intubation if the heart stops or breathing fails. It should not change anything else about their care, giving antibiotics, managing pain, wound care, basic nursing. Surgeons should really try to have these conversations and clarify surrogates before major elective surgery, because once someone is critically ill, there's often no time.
Okay, let's move into the very sensitive area of withdrawing and withholding life-sustaining therapies. Is there an ethical difference between stopping a treatment versus never starting it?
There's a strong consensus now in medical ethics and law that fundamentally there is no ethical or moral difference between withdrawing, stopping a life-sustaining treatment, and withholding, not starting one, provided it's no longer beneficial or aligns with the patient's wishes.
Why is that? It can feel different.
It can feel different emotionally, especially for families and sometimes clinicians. But ethically, the reasoning is that in both cases, the underlying disease process is what leads to death, not the physician's action or inaction regarding the treatment. The intent is to cease providing burdensome or unwanted interventions.
This equivalence was really solidified by some key court cases, starting with Karen Ann Quinlan in 1975.
Right. Quinlan was in a persistent vegetative state on a ventilator. The New Jersey Supreme Court eventually ruled that her parents, acting as her surrogates, had the right to have the ventilator withdrawn. This established the right to refuse or withdraw extraordinary life-saving technology based on the patient's perceived wishes or best interests.
And then the Nancy Cruzan case in 1990 took it further, specifically addressing artificial nutrition and hydration feeding tubes.
Yes, Cruzan was also in a persistent vegetative state after a car accident. Her parents wanted to stop artificial nutrition and hydration. The case went all the way to the U.S. Supreme Court.
And the ruling.
The court affirmed that a competent person has a liberty interest, protected by the 14th Amendment, to refuse any unwanted medical treatment, including artificial nutrition and hydration. Crucially, they stated there was no legal distinction between ordinary care like tube feeds and extraordinary care like ventilators. All life-sustaining treatments could be refused.
But there was a condition.
Yes. The court also ruled that states could establish procedural safeguards, including requiring clear and convincing evidence of the incompetent patient's wishes before allowing treatment withdrawal.
Which puts a high bar on proving what the patient would have wanted, protecting the state's interest in preserving life unless the patient's prior wishes are really undeniable.
Exactly. That clear and convincing standard emphasizes the need for things like advance directives or well-documented conversations. And these difficult decisions often bring up the principle of double effect, especially when managing symptoms at the end of life.
Okay, let's define the principle of double effect carefully in this surgical or end-of-life context.
It applies when an action is foreseen to have two effects, one good and one bad. The principle states that it's ethically permissible to take an action intended only to produce a good effect, like relieving severe pain with opioids, even if you foresee that the action might also have a bad effect that you do not intend, like respiratory depression potentially hastening death. The key is the physician's intent.
And there are strict conditions that must be met for this principle to apply, right? 4 of them.
Yes, 4 conditions. 1, the action itself must be morally good or at least neutral. Giving medicine is neutral. 2, the person must intend only the good effect, pain relief, and merely tolerate or foresee the bad effect, hasten death. 3. The bad effect cannot be the means by which the good effect is achieved. You can't intend to hasten death as a way to stop suffering. And 4. There must be a proportionally grave reason to permit the bad effect. The good effect, relieving suffering, must be significant enough to outweigh the foreseen bad effect.
That sounds like a rigorous justification needed, although you mentioned a caveat earlier.
Right. It's important to remember that while opioids are the classic example taught with double effect, in most clinical situations, pain and other symptoms can be managed effectively with careful titration of opioids without significantly hastening death. So while the principle provides ethical cover in potentially difficult cases, you often don't even need to invoke it for routine good symptom management.
Good point. Finally, when a decision is made to withdraw or withhold life support, what are the key clinical management principles?
Well, ethically, any treatment can be withdrawn if it's no longer meeting goals or desired. Clinically, it's crucial to be aware of the powerful symbolic meaning some treatments hold for families, especially things like nutrition and hydration. Communication needs to be ongoing and compassionate. Involving spiritual care chaplains, pastors, rabbis can be incredibly helpful. And critically, if there's significant conflict or disagreement, especially about futility, get an ethics consultation early. While a surgeon isn't obligated to provide care they deem futile, they do have an obligation to facilitate a safe transfer to another provider if the family insists on continuing treatment the surgeon disagrees with.
Let's shift to a very specific surgical scenario that fundamentally challenges the do no harm principle. Living, donor liver transplantation, or LDLT, this seems like a huge ethical hurdle.
It's arguably one of the most complex ethical procedures we do. You have two patients. One is critically ill, needing a transplant. The other is perfectly healthy, the donor, who we are intentionally subjecting to a major operation, a partial hepatectomy. This surgery carries real risks for the donor, including a small but definite risk of death, historically cited around 0.15%.
Okay, a 0.15% mortality risk for a healthy person. That's a direct violation of nonmaleficence for the donor. How can this possibly be justified ethically?
It rests on a balance of principles. For the recipient, the benefits are clear. They get a potentially life-saving transplant much sooner than waiting on the deceased donor list, potentially with better outcomes.
Okay, benefit to the recipient.
For society, it increases the overall organ pool, which aligns with the principle of utility, making the most efficient use of a scarce resource. And for the donor, the justification lies in the principle of autonomy, combined with the profound benefit of altruism, the immense psychological and emotional satisfaction of saving or dramatically improving the life of, usually, a loved one.
Given those risks, the informed consent process for the donor must be incredibly rigorous. They're often under immense emotional pressure to save a family member.
Absolutely. The consent has to be bulletproof. Full disclosure of all risks, including the local institution's complication and mortality rates, not just generic national stats. There must be ample time for consideration, completely free from coercion. Institutions performing LDLT are required to have robust safeguards, often including an independent donor advocate team, psychological screening, and ethics committee oversight, specifically to protect the donor's autonomy against that pressure. And critically, the surgeon operating on the recipient should not be the primary person obtaining consent from the donor.
Needs that separation. Okay, let's broaden out now to palliative care, PC. This field has really evolved beyond just being about care for the dying.
Massively. The World Health Organization defines palliative care as an approach focused on improving the quality of life for patients and their families facing life-threatening illness. And the key is how, through prevention and relief of suffering, by early identification and meticulous assessment and treatment of pain and other problems, physical, psychosocial, and spiritual.
And the crucial point is when it's offered.
Exactly. PC is offered concurrently with all other appropriate medical treatments. It's not an either with curative care, especially early on. It can be provided alongside chemotherapy, radiation, surgery. The focus is different. It's on managing symptoms, supporting coping, clarifying goals, enhancing quality of life, regardless of the prognosis.
It's not just for when curative options have run out.
Not at all. And surgeons have a huge role to play. In fact, the term palliative care was coined by a Canadian surgeon, Balfour Mount, back in 1975. Surgical palliative care involves procedures aimed specifically at relieving suffering or improving function, like debulking a tumor causing pain or placing a stent to relieve an obstruction, even if the surgery won't cure the underlying cancer. The decision is based on whether the intervention meets the patient's palliative goals.
For listeners aiming for mastery, what are the key triggers, the clinical situations, where the sources say a palliative care consultation is really indicated?
Table 48-1 in the source material gives some clear indications. 1. patients with progressive life-limiting conditions, especially if they have declining function or high symptom burden. 2. When help is needed to clarify goals of care, maybe shifting focus from cure to comfort. 3. Assistance with resolving tough ethical dilemmas. 4. If a patient or their surrogate explicitly declines further curative therapies. 5. Patients expected to die soon, either in hospital or shortly after discharge. And finally, 6. When staff need bereavement support after a particularly difficult case.
And it's vital we distinguish palliative care generally from hospice care specifically.
Yes. Hospice is a specific type or delivery model of palliative care. It's specifically for patients who have a prognosis of 6 months or less to live if the disease runs its natural course. Hospice focuses intensively on comfort, support, and quality of life in those final months, often enabling people to die at home.
And early referral is key for that goal.
Crucial. Most Americans say they'd prefer to die at home, but the reality is about 75% die in institutions. Early hospice enrollment can help bridge that gap.
At the heart of palliative assessment is understanding the patient's experience of illness, captured by the concept of total pain.
Right. Arthur Kleinman, the medical anthropologist, talked about medicine's dual role. Controlling the disease, yes, but also caring for the illness experience. Cicely Saunders, a pioneer of the hospice movement, developed the concept of total pain. It recognizes that suffering isn't just physical, it's the sum total of distress across 4 interconnected domains.
What are the 4 domains?
Physical pain and symptoms, obviously, but also psychologic distress, anxiety, depression, fear, social or socioeconomic burdens, financial strain, isolation, family stress, and spiritual or existential suffering, loss of meaning, questions about faith, grappling with mortality. You have to assess and address all 4 to truly relieve suffering.
Effective palliative care hinges on good communication and prognostication. But predicting survival, especially in advanced illness, is notoriously hard.
It is incredibly difficult, and doctors are often overly optimistic. But having some sense of prognosis, even if imprecise, is necessary to help patients and families make realistic plans and shift goals of care when appropriate. And the single most powerful predictor of survival across many advanced diseases is the patient's functional status.
How they're able to function day to day.
Exactly. There are tools like the ECOG, Eastern Cooperative Oncology Group, SCORE, or the Palliative Performance Scale, PPS, that quantify this. The source material gives a simple but useful guide based on function.
Can you walk us through that? How does functional decline correlate roughly with prognosis?
Generally, if a patient with advanced illness is spending more than 50% of their waking hours resting or sleeping and needs significant help with basic activities of daily living, ADLs, their prognosis is usually measured in weeks to maybe a few months.
Okay. And if they decline further?
If they become essentially bedfast, totally dependent for all care, perhaps with very limited oral intake, the prognosis often shortens to days to maybe a few weeks. Knowing these rough time frames, while hard to hear, allows for meaningful conversations about how the patient wants to spend their remaining time.
Delivering that kind of news is one of the toughest communication tasks. How should clinicians approach it?
There are structured models, like the SPIKES protocol, which stands for Setting, Perception, Invitation, Knowledge, Empathy, Strategy Summary. The sources outline a similar 6-step approach. First, setting. Private, comfortable, enough time. Second, listen. Find out what the patient and family already understand or perceive. Ask before you tell.
Okay.
Third, give a warning shot. Prepare them gently, like, I'm afraid the news isn't what we hoped for. Fourth, knowledge and silence. Share the information clearly and simply, then stop talking. Allow silence for them to absorb and react. This is crucial.
Resist the urge to fill the silence.
Absolutely. Fifth, empathy and encourage. Respond to their emotions with empathy. Acknowledge the difficulty. Offer realistic hope, not false hope of cure, but hope for comfort, for support, for not being abandoned. And sixth, establish expectations planning. Discuss next steps, what to expect, and formulate a plan together. Throughout it all, empathy is key.
Let's focus now on the clinical picture as death approaches the syndrome of imminent demise. What are the specific signs clinicians look for?
As someone nears the end of life, there are often predictable physical changes. The person becomes progressively weaker, more bedbound. There's usually a significant decrease in appetite and thirst they take and very little food or fluid. Oral care becomes critical because the mouth gets very dry, which can be uncomfortable. This isn't usually true thirst, but dryness from mouth breathing, medications, maybe oxygen.
And the breathing patterns change too, which can be alarming for families.
Yes. Secretions can pool in the back of the throat because the cough reflex weakens and swallowing diminishes. This can cause a gurgling sound, sometimes called the death rattle, which is often more distressing for observers than the patient. The breathing pattern itself often changes to what's called Cheyne-Stokes respiration.
Describe that.
It's a cycle of progressively deeper, faster breaths, followed by a slowing down, and then a period where breathing stops entirely apnea before the cycle restarts. It reflects changes in the brain's respiratory center and circulation.
What about circulation and other signs?
Circulation slows down. The hands and feet often become cool, maybe mottled or purplish. That's poikilothermia. Urine output decreases significantly, and often there's loss of bowel and bladder control, so incontinence.
And cognitively, what changes happen there?
Confusion, disorientation, and delirium are very common. Sometimes it's a quiet delirium, but sometimes it's agitated delirium, which can be very distressing and is a hallmark of a difficult dying process requiring active management. People often become increasingly somnolent, sleeping much more. Some report very vivid dreams or even visual hallucinations, waking dreams.
Is there awareness even if they seem unresponsive?
That's a critical point. Even someone who appears comatose may still be able to hear or sense presence. We should always assume awareness is possible. And one subtle physical sign you might see in very cachectic patients is they lose the retroorbital fat pads behind their eyes, making it hard for them to fully close their eyelids even when sleeping.
When managing these common end-of-life symptoms, what are the guiding principles for using medications and interventions?
The main goals are comfort and dignity. Key principles include anticipate symptoms and treat them proactively. Minimize burdensome technological interventions, favor simpler routes and medications. And plan for alternative medication routes, subcutaneous, rectal, sublingual, transdermal, because swallowing often becomes impossible.
Let's talk pain management. The World Health Organization, WHO analgesic ladder, is the standard framework, especially for cancer pain.
It is. It's a simple, effective three-step approach. Step 1 for mild pain. Use non-opioids like acetaminophen, Tylenol, or NSAIDs like ibuprofen, possibly with an adjuvant drug. Step 2 for moderate pain. Add an opioid typically used for mild to moderate pain like codeine or hydrocodone, often in combination with a non-opioid plus or minus an adjuvant. Step 3 for severe pain. Use a stronger opioid like morphine, hydromorphone, oxycodone, again, potentially with a non-opioid and/or adjuvant medication tailored to the type of pain.
You keep adding layers as needed.
Exactly. The goal is to climb the ladder until the pain is controlled using regular dosing around the clock, plus breakthrough doses as needed.
Regarding the specific opioids used in Step 3, morphine and hydromorphone are common. What about things like fentanyl patches or methadone? Any special warnings?
Big warnings. Fentanyl patches release the drug slowly over 72 hours. They are absolutely not for acute pain or for patients who haven't been on other opioids, opioid naive. Starting a patch on someone not tolerant can be lethal due to respiratory depression. Methadone is very effective, especially for complex pain, but it has a very long and unpredictable half-life. It requires expert knowledge to dose safely to avoid dangerous accumulation.
And a really crucial point about opioids near the end of life.
Yes, never abruptly stop opioids just because someone is becoming very sleepy or less responsive. This can trigger severe withdrawal symptoms, agitation, pain, sweating, causing immense distress. If sedation is excessive, the dose should be carefully reduced, not stopped cold turkey.
What about dyspnea, that feeling of air hunger? It sounds terrifying.
It often is. The primary pharmacologic treatment, perhaps counterintuitively, is low-dose opioids. They reduce the brain's perception of breathlessness and slow the respiratory rate. Careful titration is key. Non-pharmacologically, simply having cool air moving across the face, like from a small fan, can provide significant relief by stimulating facial nerves. Supplemental oxygen might offer subjective benefit, but it needs to be humidified to prevent worsening mouth grayness.
And managing cognitive changes the somnolence versus the delirium.
Increasing somnolence is often part of the natural dying process and may just require reassurance and adjusting the environment. Delirium, especially if agitated, often needs treatment, usually with neuroleptic medications like haloperidol. But here's a critical point. Sometimes, especially in the elderly or frail, increasing doses of opioids or benzodiazepines can actually worsen delirium. So careful assessment is needed to figure out the cause.
Once death occurs, there's a formal process for pronouncing death.
Yes. The physician confirms death by looking for specific physical signs. No response to stimuli, no heartbeat, auscultated, no respirations observed, fixed and dilated pupils, changes in skin color, cooling of the body, poikilothermia, and often relaxation of sphincters. One important caveat. If the person is profoundly hypothermic, very cold, death shouldn't be pronounced until after rewarming attempts because severe hypotonia can mimic death.
What happens after pronunciation?
The physician completes the death certificate. There might be discussions about autopsy if indicated, or organ tissue donation if appropriate and not previously arranged. Families need time and space, and their religious or cultural rituals should be accommodated. Procedures vary by location, especially for deaths at home involving hospice or sometimes police notification.
We should also briefly touch on aid in dying. What's the current status?
Aid in dying, also called medical assistance in dying, MAID in Canada, or physician-assisted dying suicide in other contexts, is legally permitted under strict conditions in a few places, several European countries, Canada, and currently 6 U.S. states.
And what do these laws typically allow?
They allow a mentally competent adult patient who has a terminal illness with a prognosis usually of 6 months or less to request and receive a prescription for a lethal dose of medication from their physician, which the patient must then self-administer. The physician prescribes, the patient takes the dose.
What are the main ethical debates around this?
They are intense. Key issues include the distinction, if any, between this and euthanasia, where the physician administers the dose, the fundamental morality of a physician participating in an act intended to end life, concerns about potential coercion or vulnerability, and how institutions handle conscientious objection, the right of clinicians to refuse participation based on moral or religious beliefs, while ensuring patients still have access if they qualify under the law.
All right, let's shift gears to the ethics surrounding the surgeon's professional life beyond direct patient care, starting with conflict of interest, COI.
COI arises anytime a surgeon has a secondary interest, financial gain, career advancement, research goals, power. Even just wanting to publish that could potentially conflict with their primary obligation, which is always the patient's best interest.
And the surgeon-scientist role seems particularly prone to this.
It is. The duty as a clinician is purely to the patient in front of you. The duty as a scientist is to the research protocol, to generating valid data, often requiring patient enrollment. These roles can clash.
How so?
Well, imagine a surgeon is running a trial. They need to recruit subjects quickly to get the study done, maybe for funding reasons or to secure authorship. This pressure could, consciously or unconsciously, influence how they present treatment options to a patient who happens to be eligible for their study, potentially downplaying alternatives or exaggerating the benefits of the trial.
To protect patients in research, there are strict ethical requirements, far beyond just informed consent. Emanuel and colleagues laid out 7 essential requirements.
Yes, these are considered mandatory for any ethical human subjects research. Let's list them. 1. Value. The research must have social or scientific value. It has to aim at improving health or increasing knowledge.
Okay.
2. Scientific validity. The study has to be well-designed, methodologically sound, and capable of actually answering the research question. Poor science isn't just wasteful, it's unethical because it exposes subjects to risk for no good reason.
3.
Fair subject selection. Recruitment should be based on the scientific goals of the study, not on convenience, vulnerability, or privilege. You shouldn't target disadvantaged groups just because they're accessible or exclude groups without a scientific justification.
4. Favorable risk-benefit ratio. Risks to individual subjects must be minimized. Potential benefits to the individual and the knowledge gained for society must outweigh those minimized risks.
5. Independent review. The research protocol, including recruitment and consent procedures, must be reviewed and approved by an unaffiliated body, like an Institutional Review Board, IRB, or Research Ethics Board, REB. They provide oversight.
6. Informed consent. We've discussed this subjects must be fully informed and voluntarily agree to participate.
And 7. Respect for enrolled subjects. Their privacy must be protected. They must be allowed to withdraw at any time without penalty. Their well-being must be monitored, and they should be informed of study results.
Now, within surgical research specifically, there are some unique challenges. Let's start with equipoise.
Equipoise is a cornerstone ethical requirement for randomized controlled trials, RCTs. It means there must be genuine uncertainty either within the expert medical community or on the part of the individual investigator about which treatment arm in the trial is actually better.
If you already believe one treatment is superior, you can't ethically randomize patients.
Exactly, because then you'd be knowingly assigning some patients to what you believe is an inferior treatment. That violates beneficence and nonmaleficence.
Why is maintaining equipoise often difficult for surgeons?
Well, surgeons develop skills and experience. They often get very good at a particular technique and naturally start to believe it's the best way. That inherent bias, born from skill and maybe phrenesis, makes it hard to maintain that state of genuine clinical uncertainty needed to ethically randomize patients between their preferred method and a new or alternative one. It's a real tension.
Another controversial area, sham surgery, using a placebo operation in a trial. Why is this so ethically debated?
The argument against it is straightforward. Surgery always involves risk anesthesia, infection, bleeding, pain. Performing an incision or procedure with no intended therapeutic benefit seems like a clear violation of do no harm just for the sake of research rigor.
But the argument for it.
Proponents argue that for some interventions, particularly those where subjective outcomes are key, a sham control is the only way to determine if the observed benefit is due to the specific surgical action itself, or just the powerful placebo effect associated with undergoing any procedure. Without a sham control, you might mistakenly conclude an ineffective surgery actually works.
And sham trials have practical issues too, like blinding. The surgeon always knows if they did the real thing or the sham.
Correct. The surgeon can't be blinded. So, to maintain the integrity of the trial and minimize bias, the protocol must ensure that the operating surgeon has very limited contact with the patient postoperatively. Outcome assessment must be done by researchers who are blinded to which procedure the patient received.
How do we draw the line between acceptable surgical innovation, maybe a surgeon tweaking their technique, and formal research that needs IRB approval?
That's a tricky distinction. Innovation often happens incrementally, a surgeon adapting based on experience or a new idea for a single patient. That's historically how surgery advances. However, if a surgeon starts using a significantly new technique repeatedly, and especially if they plan to systematically collect and analyze outcomes to see if it works, that crosses the line into research.
At that point,
At that point, formal IRB review and approval are absolutely required. Patients must give explicit informed consent, understanding that the procedure is experimental or under investigation.
since there's no FDA for surgical procedures, what's the guidance?
The ethical guidance is usually to consult senior colleagues, the department chair, or the hospital ethics committee before embarking on something significantly novel. Get input on whether it's a minor variation or truly constitutes research needing formal oversight. Transparency is key.
Let's talk about academic integrity, the ethics of authorship. Why is this such a big deal?
Authorship on a scientific paper is the primary way credit is assigned and responsibility is taken in academia. It's currency for promotion, grants, reputation. Because the stakes are high, it's been subject to abuse.
What kind of abuses?
Things like honorary authorship, putting a senior person's name on the paper just because they're the department head or secured the funding, even if they had no intellectual input. Or the opposite, ghostwriting, which is particularly problematic.
Explain ghostwriting.
That's when a paper, often written by someone working for a pharmaceutical company or device manufacturer, is published under the name of an academic physician who had little or no role in the actual research or writing. It's done to give the industry-sponsored work an appearance of academic legitimacy.
To combat this, the International Committee of Medical Journal Editors, ICMJE, came up with strict criteria for authorship. There are 4, and you have to meet all of them.
Correct. All 4 are mandatory. 1. Substantial contributions to the conception or design of the work, or the acquisition, analysis, or interpretation of data. 2. Drafting the work, or revising it critically for important intellectual content. 3. Final approval of the version to be published. And 4. Agreement to be accountable for all aspects of the work, ensuring its integrity. You have to stand by the whole paper, not just your part.
And crucially, things like just getting funding, supervising the research group, providing administrative support, or just editing the manuscript, those are not sufficient for authorship.
Explicitly not. People who only do those things should be listed in the acknowledgement section, not as authors. This is why research teams need to have clear, upfront discussions about who is expected to contribute what to qualify for authorship.
Okay, our final topic, clinical ethics. Disclosure of errors. When something goes wrong, is telling the patient optional?
Absolutely not. Disclosure of medical errors, typically defined as preventable adverse events, is a fundamental ethical mandate. It stems directly from the virtue of candor, honesty, transparency, and the principle of respect for persons. Patients have a right to know what happened to them, especially if it caused harm.
What are the consequences of not disclosing?
Failing to disclose corrodes trust, trust in the individual physician, trust in the institution, trust in the profession. It prevents the patient from understanding their condition and seeking appropriate follow-up care for the consequences of the error. It's a serious breach of professional ethics.
Surgeons have the long-standing tradition of mortality and morbidity, M&M conferences, to review complications. How does that fit with disclosure to the patient?
M&M is an internal peer review process. It's often protected by legal privilege, meaning the discussions are confidential and generally not shared with patients. While valuable for learning within the profession, M&M is not a substitute for direct disclosure to the patient. And critics, especially after the To Err is Human report, point out that traditional M&M often focuses on individual blame rather than analyzing the systemic factors that contribute to errors.
So the ethical duty is separate from M&M.
Completely separate. The duty of candor is owed directly to the patient.
What about disclosing an error made by a colleague or another member of the team?
That's delicate, but the principle remains the same. The surgeon's primary obligation is to act as the patient's agent and advocate. If you have clear evidence that an error occurred and caused harm, even if made by someone else, you generally have an ethical obligation to ensure the patient is informed. This needs to be done carefully, factually, and non-judgmentally, focusing on what the patient needs to know for their ongoing care and decision-making. #outro.
Wow. We have covered an immense amount of ground in this deep dive into the moral compass of surgery. We really started at the beginning with Aristotle's phronesis practical wisdom and laid out those 4 pillars: autonomy, beneficence, nonmaleficence, and justice.
We did. We traced the legal journey of consent from Cardozo's simply protecting the body in Schloendorff to the patient-centered standard of Canterbury. We wrestled with the limits of living wills, the sobering data on surrogate accuracy, and how the Cruzan case grounded the right to refuse treatment, even feeding tubes, in the Constitution.
We confronted the inherent ethical tension in procedures like living donor liver transplantation, balancing harm to the donor against benefit and altruism, and we mapped out the expansive domain of palliative care, understanding total pain, the importance of functional status for prognosis, and how to deliver difficult news with empathy using structured approaches like spikes.
And finally, we navigated the complexities of professional ethics. The rigorous requirements for research involving human subjects, the challenge of maintaining genuine equipoise, the controversy around sham surgery, the critical ICMJE criteria for authorship, and that absolute ethical imperative for transparency and candor when disclosing medical errors.
I think this journey really underscores that mastering surgical ethics isn't about finding easy answers in a rulebook. It's about developing the ability to clearly see what is at stake in any given situation, which values are competing, which principles apply.
Exactly. The real challenge isn't memorizing the definitions. It's consistently exercising that practical wisdom, that phronesis, day in and day out, often under pressure and with imperfect information. That's the true mark of professional excellence in this domain.
That's the mastery we aim for. To leave you, our listeners, with something to reflect on.
Consider that finding surrogates predict patient wishes with only about 68% accuracy. Knowing that, how might it change the way you personally approach conversations about end-of-life planning with your own family? How will your understanding of candor shape not just how you'd want doctors to talk to you, but how you prepare for those future possibilities yourself?
Thank you for joining us for the deep dive.